Hi, everyone, and welcome to SCN8A Unraveled. I'm Sarah Tay with the International SCN8A Alliance, and today I'll be interviewing Ángel Aledo-Serrano, a neurologist at Vithas Madrid Neuroscience Institute. Ángel, would you like to introduce yourself?
Yes, thanks for having me to start with. I'm a neurologist and epileptologist working in Spain, in Madrid, and I'm more specialized in the area of developmental epileptic encephalopathies.
Great. We're so happy to have you here to talk to us about your research on fenfluramine. So, to start from the beginning, how did you get on this research path?
Yeah, so we know that there are huge unmet needs for people with SCN8A DEE, starting with refractory seizures, which are one of the main issues for the community. And specifically, we don't have precise or clear drug algorithms, although we are working on some guidelines now internationally with the help of SCN8A Alliance. And sometimes we have only treatments for treating seizures, so we don't know how to treat or improve comorbidities. So because of that, we started to think about fenfluramine as a treatment in SCN8A, and this drug has a really interesting history. It was developed for weight loss during the 80s, and then it was withdrawn from the commercialization because of cardiac problems. But then some neurologists in France and in Belgium started to use it for developmental epileptic encephalopathies with huge effectiveness. And because of that, there was what we call the Belgian persistence, where only in Belgium they were using the drug. So just few years ago, Zogenix, a startup drug company, they started to rule some clinical trials on Dravet syndrome and then in Lennox-Gastaut syndrome. And then we know that it's safe and it can be used for developmental epileptic encephalopathies. And we know that the effectiveness is quite big compared to what we are used in the epilepsy field when we talk about these dramatic developmental epileptic encephalopathies. And we started to see not only good effectiveness, but also long-term safety according to the data we were seen in the echocardiographies. So these patients were followed with echocardiographies to see that there were no heart issues.
Wow. So then what made you think that this would work for SCN8A?
Yeah, so at the beginning we were using it only in Dravet syndrome. So we had patients with Dravet-like syndrome and variants in SCN8A. And because of that, we used it in these patients, and we saw that it was very effective, similarly to what we were seeing in the typical Dravet syndrome with the SCN1A loss of function. So then because of that, we use it in other patients, and we published this cohort. It's a very, very small cohort, only 3 patients, but we wanted to publish it to help other clinicians, but also families to have more opportunities and to try to get this drug. And these are the 3 patients where we tried the fenfluramine with very different ages, from 2.5 years to 12 years of age. And also they had really different SCN8A variants with really different functional effects. So we see that this drug is not precision medicine. It's not precise, but it's effective. and it could be used in a typical phenotype of gain of function, so a severe case of SCN8A DEE with this variant, but also in a case with a DEE related to a loss of function, which is the opposite, and also a really different phenotype with a patient, a teenager patient with a mosaic variant. So the variant was present only in 19.2% as a somatic mutation. So this is very interesting. It's not only it's only useful for a specific type of a CN8A. So these are the basal features. These were really patients with a dramatic epilepsy. We have used before between 8 to and 16 anti-seizure medications, different anti-seizure medications. And they had, all of them, they had daily seizures, multiple types, convulsive seizures, absences, etc. And they started fenfluramine either or in the Dravet clinical trial or as compassionate use as off-label. So we started with this posology. We started with 0.2 milligrams per kilogram per day at the beginning, and we went to the maximum dose, which was 0.7. And the co-medication, this is interesting. Of course, it's very small cohort, but it was 3 of them, they were using sonisamide. One patient had only sonisamide associated with fenfluramine. The other, the loss of function, he was with brivaracetam and clobazam, and the other, which was a classic gain of function DEE phenotype, she was using oscarbazepine, vigabatrin, and clonazepam. And there was, this is also important, no relevant issues regarding adverse events, except transient irritability in one of them. This is quite typical for fenfluramine. When we see large improvements in seizure control, then we see that there are behavioral issues because the patient is more aware with less seizures, and then we can have behavioral issues. So regarding the results in seizures, there was a relevant seizure reduction. Between 60 and 90% of the seizures were reduced, and there was also a reduction in seizure intensity and duration. And one patient had very frequent status epilepticus, and he stopped having them. And in addition to that, they had better attention and better motor functioning with better posturing. And this is the case of Maria. Maria is the patient with the mosaic variant. And this is how she was walking before the treatment, and this is after the treatment. So you see that the posturing is much better. She could walk alone better.
Wow, that's incredible. I mean, it looks so promising for the SCN8A community. So, what is your experience with fenfluramine outside of SCN8A?
Yeah, so our experience, as many others, is with Dravet syndrome, which is the first indication. We have so far 62 patients with Dravet, some of them from the trials, from some of them from the early access program, and we have a large retention rate, almost 80%. 50% of them, they are seizure-free. And we are seeing this also, these cognitive improvements. These improvements, it's a matter of discussing if it's proper mechanism of action of the drug, or maybe it's just the effect of seizure reduction. So we are improving seizures, and then we have a better cognitive functioning. But we are seeing this data, it's already published in Dravet syndrome, that we have better cognitive executive function, attention, concentration, behavior, sometimes after treatment with fenfluramine. And also we have, because one of the questions we have with these drugs, because this drug was primarily studied in children below 18 years of age, but now we have some publications like this publication with the participation of our group. It's a European study. We see here that adults have also a really good effectiveness. So it's quite similar to the effectiveness we see in children and adolescents. Of course, we need more evidence, but the first data we have is quite encouraging.
Yeah, these results look really stunning. So then, is this only for severe gain-of-function mutations, or have you used this in any other cases?
Yeah, that's a really good question. And what we are seeing is that it's not precision medicine. This is working for many different SCN8A phenotypes. And this is a case, the last case we have started to treat with fenfluramine. And it's an adult, and it's a different clinical scenario. She was an adult. She is an adult with a moderate intellectual disability and epilepsy without a genetic diagnosis. She had frequent seizures every 2-3 days with visits to the emergency department. The first seizure was at the age of 8 months with febrile generalized tonic-clonic seizures. She had also absences, and she was refractory to all treatment tried. So we performed in this patient genetic testing, and we saw this variant. This is the DNA position and the amino acid position. And the interesting thing is that this variant is it was predicted to be gain of function. And it's interesting because we have different phenotypes in SCN8A, different manifestations. We have the loss of function, and we have the patient with loss of function responding to fenfluramine. We have the classic or traditional severe gain of function phenotype. We had also a mosaic case. And but this case could be like more an intermediate phenotype, we call moderate gain of function, because she could walk, she could talk, she had a moderate intellectual disability, and because of that we started with double sodium channel blocker, and there was huge improvement, but still she had seizures. So then we added fenfluramine, and she became completely seizure-free with better cognitive situation, better attention, sometimes worse behavior, because we have this balance sometimes of better in seizures and sometimes worse in behavior.
Yeah, that's really great to know. So then, what happens from here?
Yeah, so this is really a small cohort. It's only 4 patients. So it's encouraging. We hope it will help other clinicians to use it for patients with variants in SCN8A. But of course, we need more data. We are planning a new study, including patients already treated in other centers, other colleagues internationally. So if your child or if your patient, if you are a clinician, has a SCN8A DEE and is on fenfluramine, it would be nice to have this data, collect this data, and make a publication all together to understand, to deeper understand how fenfluramine is working for this developmental epileptic encephalopathy. And this is all. Thank you so much.
Thank you for all your time and hard work. You've been doing so much great work for the community, and we just appreciate you so much. So to the rest of you, thank you for joining us for this episode of SCN8A Unraveled, where we unravel the science of SCN8A.